Well, good afternoon, everyone, and welcome back. My name is Robert Boy. This is the Immunization Coalition's 2022 Annual Scientific Meeting, Session 5. Our first speaker is Professor Ian Barr, who will be talking to us about influenza. He's been involved in the field for decades. Who better to talk about that topic? Specifically, he has worked as Deputy Director of the WHO Collaborative Centre for Reference and Research on Flu for so many years I can't remember, but he has had over 35 years experience in biological research in academic institutions. He's an honorary senior research fellow at Federation University, and he holds an honorary position at the University of Melbourne as well. Really looking forward to your talk, Ian. Thank you.
Thanks very much, Chairperson. Today I've been asked to give a bit of a review on the 2021 influenza season and what to expect in 2022. My usual gig, so here we go. So 2021, I'm not telling you anything you don't already know, that it was a record low year for influenza in Australia. In fact, probably one of the lowest seasons ever recorded. And this is a little snippet taken from the ABC News. And I think it encapsulates a lot of what the sort of thing we're thinking about. It's low, but when it returns, will it be a problem? And there's some comments there from the experts there, which I think are quite valid. When international borders open, as they have been or are being reopened, how severe will the 2022 season be? And influenza vaccine is still the best preventative for us to rely on against influenza. So we'll come to that as we go through. So how was the season for you? I won't dwell on this because we all know that 2021 was another COVID-19 impacted season with little or no influenza. So that's 2 years in a row, 2020 and 2021. So we'll see what happens in 2022. So just to give you a quick summary of the season, it was really a non-season in 2021. The NNDSS lab-confirmed influenzas, which is one of the measures we use, up to the 7th of November had recorded only 598 cases of lab-confirmed influenza, and that compares to 21,000 in 2020 and a monstrous 313,000 odd in 2019. And in fact, these are the lowest numbers recorded since influenza became notifiable in 2001. And some of the other readouts we use, the aspirin GP ILI data is in a flat line, as I'll show you later, and the flu tracking system, which is the online reporting system for ILI and now COVID, has been flat line-ish. The few viruses we did see were mainly influenza A, mainly influenza H3, with a few B viruses, and interestingly, no B Yamagata viruses whatsoever. In terms of hospitalization, the FluCan data showed that there was only a single hospital admission, and they weren't even admitted to ICU. So unbelievable year in terms of cases and disease burden for influenza. And in terms of deaths, there were no deaths in 2021 that have been attributed to influenza, compared to 37 in 2020 and 902 in 2019. So here's some of these flat lines that I've been talking about here. Here's the GP ILI surveillance, which is done by aspirin, and the 2021 is shown in the red line there, more or less bumping along the bottom of the screen. I'll just bring up my pointer here so you can see here on the line here, virtually no activity as recorded by ILI. In terms of lab confirmed, this is the NNDSS data, and you can see they've had to go to this insert box here to get any sort of recordings. And you see the numbers of viruses or influenza viruses detected is been in the 10s to 20s to 30s throughout the whole of 2021. Again, shown in the red line here, running along the baseline. By states, all states have had these spotty sorts of reports through the NNDSS, some more than others, Queensland especially. In terms of what those state reports have turned up, most have been, as I mentioned, influenza A, and most of the ones which have been subtype, which is only a small proportion, have been H3N2, with a little bit of influenza B there shown in the green. In terms of viruses we received at the WHOCC in 2021, Darwin is our new hotspot. In fact, the vast majority of samples we received into the lab, which we could confirm as influenza positive, came from Darwin. Some 56 samples were obtained from there. And it wasn't Darwin in general, it was the majority, or virtually all of these viruses came from the Howard Springs quarantine facility from returning travellers coming back to Australia, often from the subcontinent. So you can see here other states we didn't get a single virus that we could confirm from a number of states. The only other states which we had any samples from which were positive were New South Wales and a few from Victoria. And when we looked at those viruses in detail, the majority of these were H3N2 with a smaller number of B Victoria viruses and an even smaller number of the H1 pandemic viruses. So along with reduced numbers, this is global data, this is not just Australian data, but just to give you an idea that the numbers have been reduced, and also the complexity or diversity of the viruses which we've been seeing on a global basis is also reduced, and this diagram is meant to show this for both the H3N2 H1N1 viruses. So all this mixture of viruses here is being reduced down to a couple of different groupings here based on the genetic sequences of the hemagglutinin gene. And similar for the H3, not so much for the B Victoria lineage, and as I mentioned earlier, we haven't seen any B Emigrata viruses since March or April 2020. So they may in fact be extinct. And this is just summarizing here the remarkable data in terms of deaths, where we saw no deaths in 2021 compared to previous years where we recorded tens or hundreds of deaths due to influenza through the NNDSS system, which we know underreports cases generally, but maybe not in 2021. But not all respiratory disease circulation in Australia has been as heavily suppressed as influenza during the COVID-19 pandemic period. And you can see here on this graph here that this is data taken from the New South Wales Health, and it shows a number of respiratory pathogens here and how they've tracked over 2020 and 2021. So on the curve here for influenza, for example, this grey line here shows the average year for influenza occurrence confirmed by laboratory from 2016 to 2019, and in the red is 2021 and in the blue is 2020. And you can see that for some of these viruses, influenza A and B especially, they had virtually no circulation post-April 2020. Whereas other viruses such as the adenovirus, RSV, rhinovirus, and enteroviruses, they had circulation in 2020 and 2021, even though those seasons, in some cases, such as the Rsv season, was much later or delayed compared to normal, shown here in the blue, and then a reoccurrence of the Rsv in 2021 during the winter period, quite interestingly. And then there's other viruses, other respiratory viruses there, such as parainfluenza and human metapneumovirus that only circulated in 2021. So they had a year off in 2020. So you can see here, for example, the human metapneumovirus 2020 after April has disappeared, but it did come back in 2021 here. You can see a large peak of human metapneumovirus from July to October, and similar for parainfluenza. In terms of vaccines for Australia and New Zealand in 2022, this is what's in the pipeline. So the H1 component is unchanged. It's the VIC 2570. There is a change to the H3. It's the A Darwin 9 2021. And there's also a change in the B component for the trivalent. It's B Austria, and that's a B Vic component. And for the quadrivalent, we add in the B Phuket. Just to highlight that, the ones shown in red are the recommendation changes compared to 2021. And just as something of interest here, the A Darwin comes from our laboratory, the A Victoria comes from our laboratory, and the B Phuket comes from our laboratory. So 3 out of the 4 components originated in laboratories, our laboratories in Melbourne. So here's a list of the vaccines which I think are available. I think there still needs to be confirmed. Most of these are almost certain to be here. The one which I'm not sure about here is the high-dose quadrivalent inactivated vaccines, but some of the Sanofi representatives may be able to confirm at this meeting whether or not that vaccine will be available either in the private market or from the national influenza vaccines or not. The cell-based influenza vaccine will again be available, I assume, in Australia. First made available in 2021, but unfortunately we're still waiting for LARV and the recombinant proteins, such as the Protein Sciences, which is now owned by Sanofi, to make it down here into Australia, and I believe that that's not going to be the case in 2022 either. And of course, we're all waiting with bated breath to see what happens with the mRNA vaccines, but they'll be a number of years off. So I thought it would be worthwhile touching on some recent advice which has been given by the United Kingdom's Joint Committee on Vaccination and Immunisation. So they're a little bit more forward, or should I say adventuresome, compared to ATAGI in Australia. And they have changed their recommendations for the last couple of years, and I thought I'd just pull out some of their current recommendations for the Northern Hemisphere vaccine, or the UK vaccine, for 2022-2023. And so for the adults 65 years and over, there's probably not much of a change there. The only one which they are now recommending is the quadrivalent recombinant influenza vaccine for the elderly. The other two have been approved or recommended previously. Interestingly, though, there are a few little tweaks going on with some of the other groups here. So this is their recommendations for the 18 to 65 years of age. And they're now recommending the quadrivalent influenza cell culture-based vaccines, or the recombinant vaccines, over the egg-based culture vaccines. And this is mainly because of the H3 component, which we know sometimes has problems with egg adaptions, which make these vaccines less efficacious. So that's an interesting change to their recommendations. And there's also got the recommendation here for children of 2 to 18 years, and they're recommending the live attenuated vaccine, which we don't have available, and also the quadrivalent cell culture-based vaccines, which in Australia is only recommended or approved for 9 years and above. So there's a bit of a gap there for the very young children. And finally, for the two-year-olds or less than 2-year-olds, here's their recommendations here, which is not surprising. It's just the standard egg vaccines. But I did notice this other recommendation here for egg allergic children of less than 2 years, that they recommend they be offered the Flucelvax Tetra as an off-label recommendation. So I'm not quite sure what the situation is in Australia, whether that is a feasible option or not, but interesting to see that. So the other thing which to take into account this year, or this 2022 vaccination season, will be the issue again with influenza vaccines being given at the same time or similar time to SARS-CoV-2 boosters. This is the data which was current as of December 2021, and this referred to the influenza vaccines of 2021. I'm assuming that they will give a similar recommendation for the 2022 influenza vaccinations, but to date I haven't been able to find that. But if Chris Blythe or others from ATAGI are on this meeting or at this meeting, they might be able to confirm that this will be the case. So currently, as it stands, there is a recommendation for co-administration of COVID-19 vaccines with influenza. Could be at the same time on the same day. I'm not sure whether they're still recommending to put it in different arms, but that sounds like it would be a reasonable suggestion. So this is again the 2021 vaccine, so we just have to wait a little bit longer to see what the recommendations of the 2022 influenza vaccination will be, but I suspect it will be very similar. So in 2021 we also had the Australian Immunization Register come on board with influenza vaccinations. And there's a few observations that I'd like to make there. So there were some 20.5 million doses made available to the market in 2021. That would be enough to cover more than 80% of the eligible population. In fact, that's a record number and exceeds even 2020, which was the previous record of 80 million doses being made available. However, by the AIR records, only approximately 9 million vaccines were administered, and that's something around 35% of the eligible population, and means we only use 43% of the available vaccines, which seems like a bit of a waste for everybody concerned, really. And what we saw was reduced vaccination rates in the less than 5-year-olds and the 5 to 64-year-olds. Fortunately, there's still high vaccination rates of around 80% in 65-year-olds. And if you want to look at this data in detail, then you can pull that up on your computers and have a look at each state and each age group, and whether they're Aboriginal or Torres Strait or not, and where the vaccines were given. Not surprisingly, most vaccines were given in GPs, but the pharmacies did offer around 15% or a little bit more of the vaccines administered. So just briefly to cover the Northern Hemisphere 2021-2022 influenza season, and I'll also look a little bit elsewhere. So here's the WHO map showing you activity. So the heat map, the coloured countries show the heat map. So the lighter yellow, the less influenza positive cases there are, and the stronger the yellow colours, the more influenza cases there are. So you can see from this that North America is relatively light in terms of influenza positive cases. So are many parts of Europe and many other parts of the world. Interestingly, some of the countries which you would normally associate with low activity at this time of year in the Southern Hemisphere, such as Brazil and Argentina and Chile, have some activity there, South Africa included. So that's an interesting aspect, but other countries are also seeing influenza such as Russia and China and Mexico. But looking at some of the Southern Hemisphere outbreaks, most of those have been in summer, and you can see here that in South Africa they've had a small blip here, mainly H1 pandemic viruses, but a little bit of B, and Chile, which is normally has very little activity at this time of year, has had mostly H3, although not much. Brazil has had mainly H3, more numbers there, whereas Australia, we're still flatlining here, as I've shown you earlier. So what's happening in the Northern Hemisphere? Here's what's happening in the Northern Hemisphere. And again, 2020, after March, April, nothing. Very little through 2021 up until this current period here. But you can see the size of the peak here is much reduced from previous years. So this is 2019-20 and 2018-2019. So you can see we're well less than half, probably a third or a quarter of what we would normally see in the Northern Hemisphere at this time of year, and with a trend down in cases currently. So here's just a few countries picked out. USA, so we're seeing again this big hiatus here, but some rebound here of H3 viruses. China, very interestingly, is all BVIC viruses, no influenza A whatsoever here, but again, the numbers are probably half or a quarter of what we would normally see there. The UK, again, this hiatus with a very low level of activity there currently, with mixed viruses circulating there, H3 and BVIC. And in India, where a number of the cases we've turned up in Australia have originated from, have had H3 and then a series of B viruses. But again, that's tailing off in more recent times. So an interesting variation from country to country in the Northern Hemisphere. So CDC always have a lot of data on their website, so if you want to go and look out and see exactly what's happening there, you can do that. I think the trouble with a lot of the measures for influenza, which we used to rely on, such as influenza-like illness, are now muddied because of the SARS-CoV-2 data, which is now impinging on that data. But this, for what it's worth, this is their influenza-like activity, with certain states showing higher levels. And again, this is the rate here for 2021-22 shown in red. So this is their normal cutoff for saying the season has begun at 2.5% of cases here. And it's probably on the way down again, according to this data. But again, this is impinged by the COVID-19 data. In terms of actual influenza testing here, you can see here this is testing done by the public health laboratories, and they've seen mainly H3N2 and a little bit of untyped influenza A and very little influenza B. Some of the other readouts for the severity of the season, this is one which they usually corresponds quite well with the severity of the seasons here. And you can see pediatric deaths, and their pediatric deaths are less than 18 years of age. And you can see here the last 2021 period, and again in this period, current period, virtually no deaths associated with influenza in the pediatric population. Some of their other measures here, this is a hospitalization measure here, and you can see that it's relatively low, and it's coming off their peak here at a few thousand cases. Here's the cumulative cases in hospitalization. You can see here in red 2021, 2022. It's slightly higher than 2020, 2021, but again, much lower than other seasons. In terms of long-term care facilities, this is a new plot which CDC are collecting data on. And you can see here that it's a very low incidence. So their measure here is more than one case of influenza confirmed in a long-term care facility. So you can see here we're around 1% or less and dropping off, so very low. And again, this is one we used to rely on here, this excess mortality, and you can see here that these curves are all over the place now due to COVID, so probably need to be rejigged in post-COVID times. What's happening in influenza in the EU? Here's just a couple of plots taken off the ECDC website here, and you can see this one's based on intensity. So low level activity in Scandinavia and France and a few other places here. In terms of what they're seeing in Europe, Scandinavia is seeing mainly H3s, and France have got mainly A's untyped here, so that's not very useful information, and the rest very little information on type and subtype. So just one slide on the zoonotic front. I think this is the most important thing which is happening in the zoonotic world at the moment, and that is the Asian H5N1 highly pathogenic avian influenza has swept across Europe in the last 6 to 12 months and recently appeared as in early January in the USA. So there's quite some concern there. This is highly pathogenic, so it will kill poultry in very rapid times, and has also been killing some of the wildlife. So a large crane kill in Israel has been noted recently. So these viruses can be quite deadly, not only to poultry, but also to wild birds, which is a little unusual. And also there's the ongoing pandemic threat that one of these viruses might actually change a little bit or enough to transmit to humans. So there was a recent case in the UK where a man was infected with this virus. However, he was asymptomatic and got it from his ducks, apparently. So in summary, 2021 was an historically low influenza season in Australia, probably the lowest ever. It was even lower in New Zealand with only a couple of cases detected there over the whole season. The H3N2 was the predominant virus that we could detect, but very few cases. Vaccine match, again, very few viruses determined this, but if I had to be pushed, I'd say the pandemic virus was good, the H1, H3 and the B were not so good. No B Yamagata viruses have been detected and confirmed globally since April 2020. So we're hoping that that particular lineage has gone. Record numbers of vaccines were made available in 2021, 20.5 million doses, but we had reduced uptake in some age groups. No antiviral-resistant viruses were detected during this period. There was only a single hospital admission with confirmed influenza and no deaths due to influenza in 2021 in Australia. VE, too few to actually measure. We did see a resurgence of many other respiratory viruses that occurred in 2020 and or 2021, and so it's not unusual to see the other viruses circulating, and really raises the question of what's different about influenza. And the main thing that I would say there is that its introductions from overseas has had the biggest effect on influenza circulation in Australia. So so far in 2021, 2022, that should say, the Northern Hemisphere has been variable in terms of their influenza cases. They've been increasing in the US, they've been moderate in China, all influenza B viruses, BVIC, which is quite interesting. No influenza A viruses have been detected there. And interesting that Japan has had virtually no influenza circulating whatsoever so far. So the H3 and the BVIC components of the Australian New Zealand 2022 vaccine has been updated from that should be 2021. Likely to be ongoing challenges giving influenza vaccination in 2022 in the 6 months to 64 years of age if low influenza circulation continues and COVID-19 boosters are required and distribution issues continue. So I've done these predictions for a few years here. So 2019, half right, 2020, probably completely correct. 2021, got that one right, so I'm on a hiding to nothing here, but my prediction for 2022 will be, for influenza, it will be a low to moderate year with H3 viruses predominating. So here's the acknowledgements, and that's about it. Thank you for your time. Back to the chair.
Oh, that was super, Ian. Thank you so much. We now move straight into our second presentation. Our questions will be later. Pneumococcal disease and the implications of recommendations on the National Immunisation Program. And another old friend presenting, Dr. Peter Eisenberg. He's a GP who's worked, again, for decades in the field. He's a director of Doctors of Ivanhoe, and he has had special interest for many years in immunisation. He's a current member of our Scientific Advisory Committee for the Immunisation Coalition, and he's also very involved with Ausvac safety. Peter, over to you. Looking forward to it.
Thanks, Rob, for that kind introduction, and hello, everybody. My name is Peter Eisenberg, and I'm a GP in suburban Melbourne, and thanks for the opportunity to speak to you about pneumococcal disease, the implications of the National Immunisation Program recommendations. So, customary for declaration of conflict of interest and financial disclosure. There are a couple of vaccine companies that are relevant to this talk, and that's Pfizer and Seqirus, for which I have received funding for conduct of sponsored research, travel and consultancy work. But I have no ownership or shares in any vaccine or pharmaceutical company, including them. And I must say that I've neither sought nor received approval from anybody, any of the organisations for this talk, and the views expressed are my own. So we're going to talk about the implications of pneumococcal program, the background to the National Immunisation Program changes on the 1st of July as they affected pneumococcal vaccination program, the overview of those recommendations, their impact, and the implications for at-risk individuals, vaccine providers, and the community. I'm not going to cover the scientific background that's already been published by eminent members of our organisation, and that looked at the scientific background for the different schedule changes, taking into account the very significant disease burden, particularly for adult Australians, and a very widening gap between Indigenous burden on Indigenous Australians compared to non-Indigenous, and the impact of the various schedules, taking into account the strain changes in the vaccines, the epidemiological vaccine antigen changes for emerging strain replacement, and what I'm going to be focusing on rather is the vaccine provider perspective of the program, as I believe that's fundamental to the successful implementation of a program such as a pneumococcal program. So looking at the background, just in quick summary, we had existing at the time a very successful universal childhood pneumococcal vaccination program using mainly the 13-valent conjugated vaccine that was given universally at 2, 4 and 12 months, with additional doses of the 23-valent pneumococcal polysaccharide vaccine for children with high-risk medical conditions and Indigenous children in high-risk geographical areas. And we have really a cause to celebrate of 94%, with a tiny gap of Indigenous children. So if we look at the 2018-2019 immunisation register figures, the official figures for pneumococcal vaccine coverage displayed there, demonstrating the extremely high, as well as we could imagine we could get with Indigenous children and non-Indigenous children, and this very pleasing closing of the gap as of just a small percentage point of timeliness of vaccination between Indigenous children and non-Indigenous children. So huge celebration, to be contrasted with disappointing low adult pneumococcal vaccination coverage rates for all groups. including standard age-related cohorts for Indigenous over 50, non-Indigenous adults over 65, and all adults with high-risk medical conditions, with coverage estimate around 50% for the measurable over 65s, and a suspected wide gap between coverage rates for Indigenous and non-Indigenous adults. What's important to understand is how difficult it is to get accurate data for adults for pneumococcal vaccination. So last year, our organisation published a policy white paper for enhancing adult vaccination coverage rates in Australia. And the figures for pneumococcal elements demonstrated this very high existing childhood rate contrasted with the very low over 65, and suspected lower again for those who need it most, people with the high risk conditions and those with the highest risk. And this reflects similarly the disproportionately low uptake of pneumococcal vaccination measured either by doses distributed or doses recorded on the register compared to other comparable vaccines. So we have this very, very disappointing adult pneumococcal coverage rates. And not unrelated, the existing recommendations and guidelines were very complicated and confusing for everybody. The pneumococcal chapter in the handbook was convoluted, difficult to understand. The lack of clarity imposed significant time burden for all providers to interpret and to try to apply. And that has led to great inconsistency across providers who are often unable to implement or just paralysed, not even able to commence the conversation. So various groups stepped in to try to help, including the Immunisation Coalition, developing multiple guides and tools to assist providers. This was the BioCSL industry chart to try and summarise and make clear who was indicated for what vaccine and where the funding, what funding arrangements existed, with lots of footnotes, of course, to qualify. The Immunisation Coalition produced this chart to try to assist. Similarly complex, very hard to work out exactly who is funded for what, and noting that the 13-valent pneumococcal conjugate vaccine at the time that was recommended for the highest risk category was not funded under any program. So Immunisation Coalition contracted Angela Newbound and her team, including me, to try to develop a Nemo smart vaccination tool to help prompt and guide providers to make a time-efficient process of recommending pneumococcal vaccination to those who need it at most. In the background of that, we noted that the pneumococcal vaccine of the 13-valent pneumococcal conjugate vaccine recommended for the highest risk groups was unfunded and therefore out-of-pocket cost to those patients at significant cost to them, which we'll look at in a moment. There was, taking all this into account, a very clear need to lift our game for pneumococcal vaccination for all adults, particularly those at highest risk. So the National Immunisation Program pneumococcal schedule changes from the 1st of July were released, and to examine the detail here of their aims, from the 1st of July the NIP-funded pneumococcal vaccination schedule was changed to reflect current best clinical evidence in preventing pneumococcal disease in adults and in people with conditions that increase their risk of disease, and importantly, to seek to simplify vaccination advice by making it easy to understand who should get vaccinated, when, and which vaccine they should get. And there were no significant changes to the routine infant schedule for the 13-valent pneumococcal conjugate vaccine that existed. So what does it look like? To try to skip through this section so that you get an insight into what providers would have to deal with to deliver the program. There was a handy two-sided chart looking at the left side first. It identified in these different columns the indications for vaccination with pneumococcal vaccine for those at risk. And these are the risk groups, and these bars below in green and purple indicate whether it was the 13-valent pneumococcal conjugate vaccine, or the purple 23-valent polysaccharide vaccine, and in what sequence and time intervals and how many doses for each of these groups. The universal childhood schedule on the left side, at-risk children under 12 months, including all children with medical conditions that made them at risk, and Indigenous children living in certain parts of Australia. Children over 12 months, adolescents and adults of any age with a diagnosed risk condition for which they recommended vaccination under the pneumococcal program. Indigenous age-based people over the age of 50, and non-Indigenous adults who have no other risk condition other than reaching the age 70. So this begs the question of who is at risk that requires vaccination. And here is the list on the back of that chart. On the left column, it lists all those conditions for whom the pneumococcal vaccine displayed on that previous chart I showed you is recommended under the National Immunisation Program. And it's these two columns on the right, indicated with a tick box, either for this column for children under 5 years of age, and this column for everybody 5 years and over. A tick indicates that that condition is fully funded under the National Immunisation Program. But those conditions listed here that are not accompanied by a tick on this side means that there is no funding for the recommended vaccines. And to just highlight that, this revised eligibility then created a critical distinction between the National Immunisation Program recommended conditions and the NIP funded medical conditions, and noting that at the same time there was removal of the PBS listing that existed before the 1st of July 2020 for the 23-valent pneumococcal polysaccharide vaccine. So that list left out of the funded mix all of these groups for whom pneumococcal vaccination in a sequence of combination vaccines are unfunded. That is, all smokers, people with diabetes, all chronic lung disease other than suppurative conditions, those on immunosuppressive therapy, those with non-hematological malignancies receiving chemoradiotherapy, and anybody with chronic cardiac, liver or renal disease, unless their renal disease was so severe that their EGFR was under 15. So naturally, anybody who is age appropriate for having a funded pneumococcal conjugate vaccine would still get it under the program of age eligibility, and that would cover also the 23-valent vaccine for those Indigenous over the age of 50 who have these conditions. But it would be the vast majority of people in this condition are recommended to have vaccine but not funded. Just to give the background, these pneumococcal recommendations to providers to get their minds around came out at the same time there are other changes on that date, and this suite of guides that were arrived in the bundle in the month preceding the commencement of the program were what providers needed to get their minds around. Just in the pneumococcal recommendation, there were 30 or 50 pages of guidelines. All organisations recognised that these needed explanations, and Immunisation Coalition produced a chart. The Victoria and Melbourne Vaccination Education Centre, and in most other states similar, and the NCIRS produced a guideline together with frequently asked questions, multiple pages. That's on top of the coronavirus context at the same time we were getting our minds around and preparing for a vaccination program to commence later that year. So what is the impact of those recommendations? There were expected impacts, that is the improved protection from the addition of the 13-valent pneumococcal conjugate vaccine where it was not previously included. There is a small delay of the routine pneumococcal vaccine protection from age 65 that existed prior to age 70 for the commencement of the age-based non-Indigenous. The important impact was that the national immunisation program was not a cost burden for healthy Indigenous, over 50, the healthy non-Indigenous over the age of 70, and cohorts with those highest at-risk conditions. So those individuals with the medical conditions who needed the vaccine the most were at no out-of-pocket costs for this program, whereas prior to 1st of July, if they were under the age of 65, they needed to purchase 2 or 3, actually, a pneumococcal polysaccharide vaccine and a pneumococcal conjugate vaccine was not on the PBS and would cost $180 privately for them. Unexpected impacts was the continued burden for vaccine providers to try to implement the adult pneumococcal program as well as possible. The complexity remained a very significant barrier, and the recommendations were not any simpler or easier to implement other than a couple of improved charts and some guidelines. And this removal of the PBS listing for the 23-valent was really a killer blow that put the cost to being so significant for the majority of people at risk who were recommended to have vaccine under the National Immunisation Program but did not meet the criteria for the highest risk group. And those individuals were facing currently over $300 out of pocket for them to have the recommended vaccine schedule, and that includes all those groups we discussed just before. Whereas prior to the 1st of July, to be funded for the recommended schedule at the time, admittedly that didn't include for that group the 13-valent conjugate vaccine, but to comply with the program, it was $14 or $21 on the PBS script that no longer exists. So just to define the type of person that we're talking about for a particular impact that seem perversely to be left out of those recommendation-funded vaccine is the type of individual with multiple medical risk conditions, each of which qualifies for recommendation to have a national immunisation program vaccine, but and so therefore requires 3 doses in total, a 13-valent and 2 polysaccharide vaccines. But perversely, even with all of these conditions, that person would not be eligible for funded vaccine, and this type of person who needs it the most is facing out-of-pocket cost over $300. And the vaccine providers having to have these complex discussions with patients are faced, do I take the time to go over all of what we've just discussed with the patient, or do I leave them unvaccinated? Very big conundrum for providers in talking to their patients. The Immunisation Coalition had Angela Newbound go back to the drawing board with her team to develop the Nemo Smart vaccination tool and to update it for these changes. And it really is a very handy tool where just by clicking on a few boxes, entering some simple details about the patient, the provider can identify the conditions for which the patient has existing, and by submitting those details end up with a very handy vaccination report with a summary at the bottom of what vaccines are required, at what time intervals, the comments about them, and of course for this patient with all of those conditions that they're self-funded. Sadly though, not many providers are aware or use this chart. That's the summary page for that individual identifying the funding. So what does all that mean as implications for at-risk individuals, vaccine providers and the community? So for at-risk individuals, sadly, they remain mainly either underprotected or significantly out of pocket for the cost of having their vaccination, particularly a neglected cohort being those with multiple at-risk conditions that don't get the Guernsey of the highest risk group but clearly have very significant risk. Providers it's important, this program, it's fundamental that providers can implement the program, yet the majority are confused, overwhelmed and unable to implement it effectively. And for all those reasons we covered before. And this complexity contributes to the provider emotional exhaustion that we're seeing with coronavirus on top of it all. And that leaves the community with disappointing low pneumococcal vaccination coverage rates, especially for neglected cohorts of at-risk adults. And if Ian Barr will indulge me to do a scorecard, my scorecard from the vaccine provider perspective, in its goal of reflecting current best clinical evidence, I'd give it a 2+. It certainly does, and lots of discussion as that evolves and further information emerges. But is it simpler and easier to understand? I really have to give that a big X. Cost to consumers, I've put a green tick for each $100 saved for those in the highest, most risk group, but an X for every $100 out of pocket that the majority of at-risk people recommended to have a vaccine have to pay. From the provider perspective, in terms of compliance with the guidelines, an X representing the number of people missing out because the opportunity to discuss the vaccination is too difficult, and also leakage occurs in good faith with providers leaking funded vaccine to those who are not strictly eligible. Contribution to provider burnout, I've given a 2x. And that's only because the scale of 3x has to be reserved for coronavirus impact on burnout. And finally, in terms of coverage rates, I'm afraid that the age-based cohorts, there's no evidence, not a lot of evidence at all, but there's no evidence that we're doing much better than the 50%. And those are the highest at risk, those funded, even funded, are missing out because of the opportunity loss for vaccine providers to deal with it, and most adults at risk that are unfunded are remaining unvaccinated. So thank you for your attention. I look forward to speaking to you during the question and answer session following the end of the session. Thank you.
Thanks, Peter. Another great talk. I'm really excited now to introduce Dr. Gemma Savaranos. She's been working in the RSV field now for nearly 5 years. She's an academic fellow at the University of Sydney, with backgrounds in nursing, immunisation and public health. Her research seeks to better understand the burden of severe acute respiratory infection, especially and including RSV, respiratory syncytial virus, in the Australian population. The aim is to inform better prevention strategies going ahead. Welcome, Gemma.
Thank you for the introduction. In this presentation, I'm looking forward to providing you with an overview of the global and Australian disease burden of respiratory syncytial virus, which is more commonly known as RSV. I'm going to discuss the current RSV prevention landscape and some recently published clinical trial results. I'll also talk about public awareness of RSV, and I'll touch on Rsv seasonality, pre and post the COVID-19 pandemic. Lastly, I'll set some direction about the next steps needed in our efforts to reduce the burden of RSV disease. Before I begin, I'd like to acknowledge the traditional owners of the lands on which we meet and pay my respects to elders past, present and emerging, and extend this respect to any First Nations people joining us today. RSV is a leading cause of acute lower respiratory infection. The greatest burden of disease exists in infants and young children. It's important to note that young age is an independent risk factor, and the majority of children who are hospitalised for RSV disease are otherwise healthy. There are a number of other groups who are at risk of experiencing severe RSV disease, and these include premature infants, individuals with chronic comorbidities, older adults, and Indigenous populations, including Aboriginal and Torres Strait Islander Australians. There is currently no vaccine available to prevent RSV, but due to the recognised large burden of disease, the development of safe, effective and affordable vaccines is a global priority. We have one RSV-specific prevention agent available. This is a monoclonal antibody known as palivizumab. However, it is extremely expensive and its use is restricted to high-risk infants. It also requires monthly intramuscular injections during the RSV season, which provides further challenges to its delivery. Infection prevention and control strategies are similar to other respiratory viruses and include respiratory and hand hygiene, staying home when symptomatic, and in the clinical setting, we commonly use isolation, cohorting, and personal protective equipment. Treatment for RSV disease consists predominantly of supporting hydration and respiration through the administration of fluids and oxygen as needed. Characterising the full burden of RSV disease is increasingly important as we approach RSV-specific interventions such as vaccines. While there has been good progress in some areas, important gaps still remain. RSV mortality can and does occur, mostly in low-resource settings, but also in high-risk groups in other settings. There were an estimated 3.2 million Rsv hospitalizations globally in 2015. Hospitalizations are largely due to lower respiratory infections, such as bronchiolitis and pneumonia. Extrapulmonary presentations, such as severe acute neurological disease, are rarer, but do also contribute. The burden of ICU admissions is less clear, but we do know that bronchiolitis is the leading cause of non-elective ICU admission in Australia and New Zealand, and that RSV is responsible for about 2/3 of all bronchiolitis episodes. The burden of RSV-specific emergency department presentations is also less clear, but bronchiolitis is the leading cause of presentation to the ED for Australian children aged less than 1 year. Community disease is poorly characterised and may have a range of presentations, including asymptomatic disease, mild upper respiratory tract infection, and otitis media. It is important to note that diagnostic practices are highly variable across different settings and groups. In fact, routine viral testing for bronchiolitis is not currently recommended. For this reason, estimating the RSV-specific burden of disease can be challenging. Thinking first about the burden of RSV disease in young children, where we have the best data, this modelling study from the United Kingdom examined GP visits, hospitalizations and deaths, and considered that the burden of RSV disease in children was greater than that of influenza. RSV is a big driver of GP visits and antibiotic use in the community. Most children will be infected by age 2 to 3 years, and reinfections, usually less severe, occur throughout life. A recently published Australian birth cohort study found that roughly 1/3 of all children infected will seek community medical care, and around 2% are hospitalised. We carried out a study of Rsv hospitalizations in the Australian population using the National Hospital Morbidity Database. In 2015, over 7,000 RSV-coded hospitalizations occurred in children aged less than 5 years. This figure shows the rates of hospitalisation over the 10-year study period, and you can see that the rate increases with decreasing age. Infants aged less than 3 months had the highest rates of hospitalisation, around 3,000 per 100,000 of the population, highlighting the potential impact of a maternal or an early infant strategy to prevent RSV infection in these first few months of life. Hospitalizations were generally short. They had a median of 3 days. And Indigenous children were almost twice as likely to have an RSV-coded hospitalisation compared to non-Indigenous children. It's important to note that these represent minimum estimates of the true disease burden. A recent data linkage study from Western Australia suggested that RSV hospitalizations may be estimated by over 30% due to under-testing. RSV epidemics also present a substantial healthcare and economic burden. An Rsv hospitalisation in Australia was estimated to cost over $6,000 and around $20,000 for an ICU admission. To paint a picture of what severe RSV disease can look like in infancy, I'm going to share with you a photo of a previously healthy 3-week-old bub who contracted RSV and required admission to the paediatric intensive care unit. What started out as nasal congestion progressed to increased work of breathing and eventually apneas. She needed intubation and ventilation to support her breathing and the placement of a feeding tube to keep her hydrated. Her mother said of the illness that RSV is terrifying and all but completely unknown to parents. Thankfully, in well-resourced settings and with the right support, babies usually recover quite well from severe RSV disease, and this is Navy a few days later before being discharged home. Tragically, not all children have a positive outcome, and RSV is an important contributor to child mortality, with up to 118,000 deaths estimated to have occurred in the hospital and in the community in 2015. Most deaths occur in lower income countries. RSV Gold is a collaborative global study which aims to describe the clinical and socio-economic characteristics of RSV-associated deaths in children aged under 5 years. They reported 358 deaths from 23 countries and found that the age of death was lower in low-income countries, highlighting again here that potential impact of an early infant prevention strategy. In contrast, children in high-income countries tended to be older and have more medical comorbidities. Our recent study examined Rsv attributable deaths in children aged less than 16 years at a major Australian paediatric hospital. We undertook an expert panel review of any child with laboratory confirmed RSV whose hospitalisation ended in death. We found that Rsv attributable death was infrequent in this well-resourced setting, but we did identify 20 deaths over the 21-year period where RSV was considered to have contributed to the death of that child. We estimated a population death rate of 1.2 per million children in New South Wales. The children in our study were older than expected. More than half were aged over 2 years. All of the children in our study had at least one medical comorbidity, of which malignancy with immunosuppression was the most common. RSV was acquired in the hospital for over half of all cases. And lastly, only 85% listed an RSV diagnostic code, highlighting the limitation of relying on these codes to identify RSV deaths. You might be wondering about the RSV disease burden in adults. The same research group from the UK, cited earlier, also undertook a modelling study of the RSV disease burden in adults. They looked at GP visits, hospitalisations and deaths and found that the burden of disease in adults was comparable to that of influenza. Hospitalisations and deaths were concentrated in adults aged 65 years and older. Our national study of RSV-coded hospitalisations showed a 20-fold increase in hospitalisations for adults aged over 65 years over the 10-year study period, highlighting that increased recognition and diagnosis in this age group. Most were diagnosed with RSV pneumonia. Admissions were associated with long hospital stays and a high number of in-hospital deaths. Rates of hospitalisation were higher for Indigenous adults for age groups from 35 to 64 years of age. There is a general paucity of research surrounding RSV disease in Australian adults. However, many international clinical studies describe complex clinical courses and high mortality in older adults that rivals influenza disease. It can exacerbate chronic obstructive pulmonary disease, asthma and congestive heart failure. Severe disease in immunocompromised individuals is also well documented. Next, I'm going to provide an overview of the current RSV prevention landscape. Initial attempts to develop an RSV vaccine in the 1960s had a disastrous outcome and led to vaccine-enhanced disease in immune-naive children. This stalled development for some time, but now, half a century later, there's a large number of RSV-specific prevention agents in development, and there's great hope for an RSV vaccine in the next few years. We have vaccines being developed for the paediatric and elderly populations where the burden of disease is greatest. Maternal vaccines to provide protection to babies in those first few months of life, and also next generation monoclonal antibodies. The vast majority of agents target the F or the fusion protein depicted in blue on this image. The F protein is highly conserved and has a pre- and post-fusion form, with the pre-fusion form being the favoured target. The G glycoprotein, depicted in red, is more variable and gives rise to two antigenically distinct subtypes known as Rsv A and Rsv B. There are a few vaccine candidates targeting this G glycoprotein as well. This is the most recent RSV vaccine and monoclonal antibody summary from PATH. And as you can see, this is a very busy space with quite a number of candidates in late-stage clinical trials. Now I'd like to touch on a few examples of some candidates with recently published results. You may have already heard about the Novavax Phase 3 maternal vaccine trial conducted in over 4,500 pregnant women, with the aim of protecting infants in the first few months of life. While this candidate showed some promise in preventing severe RSV disease, it failed to meet the pre-specified primary endpoint, so it's now been discontinued with its future pathway uncertain. While this is a really disappointing outcome, it has really forged the way in the maternal RSV vaccine clinical trial space and continues to be a favoured approach for prevention. Of note, there are two similar candidates now in Phase 3 clinical trials from Pfizer and GSK. At the other end of the age spectrum, an adenovirus vector vaccine recently achieved an 80% efficacy in preventing RSV acute lower respiratory infection and a 70% efficacy in preventing symptomatic infection in adults aged 65 years and over. This candidate is now progressing to a Phase 3 clinical trial. The last example is not a vaccine, but a next-generation single-dose monoclonal antibody known as Nasivumab. This candidate was found to be effective in preventing RSV acute lower respiratory infection in healthy preterm infants. It's now being investigated in healthy term infants in a Phase 3 clinical trial. If it demonstrates efficacy and is priced to be widely affordable, it represents a real promise of providing early infant prevention at a population level. Next, I wanted to touch on Rsv awareness. Once we have safe, effective and affordable vaccines, we will need to motivate their uptake in the intended populations. A number of RSV awareness campaigns now exist and include this one from the Rsv Gold Group that recognises that awareness of RSV as a global health problem is lacking. We know from existing research that pregnant women and midwives have low awareness of Rsv disease. A recent Australian study estimated that 83% of pregnant women surveyed had never heard of RSV. We know that Rsv disease in older adults is under-recognised. We have busy immunisation schedules and recognised challenges with the uptake of existing vaccines. For this reason, education on the disease and the intervention when it's available will be needed. This will be particularly important for healthcare workers who we know from research are highly influential in supporting the uptake of vaccines such as the flu vaccine. Lastly, I want to touch on Rsv seasonality. Understanding and being able to predict RSV epidemics is important to support planning for both health system delivery and for the timing of interventions such as immunoprophylaxis or vaccines so that they can have the greatest impact. This figure shows the predicted prevalence of RSV for the month of July based on data from 2000 to 2017. This study gathered global data and found clear seasonal epidemics occurred in both temperate and tropical regions, starting in late summer months in the tropics and reaching most temperate sites by the winter months. They found that the RSV season typically preceded the influenza season and had a duration of roughly 4.5 months. Fast forward to 2020, however, and RSV activity has been disrupted globally. This phenomenon has now been widely published, and it's generally agreed that public health measures for COVID-19 reduced RSV transmission, and this was followed by unpredictable epidemics driven by relaxed interventions and reduced population immunity. We reported on our experience from New South Wales, and you can see in this time series RSV-coded hospitalizations stratified by age group, with the 2020 epidemic in stark contrast to the 6 previous years. We found RSV infections were significantly increased in older children. However, this did not translate to an overall higher number of hospitalizations annually. These events demonstrate that infection prevention and control measures are effective in reducing RSV disease. The challenge, of course, lies in understanding which interventions are effective and whether or not they're acceptable to the population. Also highlighted is the potential for unpredictable RSV epidemics, which are likely to continue to evolve as the COVID-19 pandemic continues to evolve. I hope my presentation today has highlighted some of the considerations for RSV surveillance and research as we approach the availability of RSV-specific interventions. Understanding RSV activity and its impact in real time is key and can only be achieved through robust surveillance efforts. RSV was recently made a notifiable condition in Australia, which is an important first step. There has also been some good progress with global RSV surveillance following a World Health Organization surveillance pilot, of which the Royal Children's Hospital in Melbourne has contributed data. Further investment in clinical and virological surveillance will be needed to establish baseline data and determine the effectiveness of interventions once they're introduced. In Australia, we're also fortunate to have good sentinel surveillance platforms for influenza disease, which can be harnessed to monitor RSV. Investment in research is also needed. There are still big gaps in knowledge, in particular for older children and adults and at-risk groups, where disease is likely substantially under-ascertained. Continuing to develop data linkage capacity nationally and beyond will support increased accuracy of disease burden estimates. Finally, we also need to invest in social research to support uptake when a safe, effective and affordable vaccine or monoclonal antibody is available. Thank you for your attention today, and I'd like to acknowledge the contributions of a great many people at the University of Sydney, the Sydney Children's Hospital Network, and the National Centre for Immunisation Research and Surveillance.
We've just had 3 great talks on the 3 of the commonest preventable viral respiratory, well, not viral, but respiratory pathogens, sorry, Peter, and 3 vulnerable groups, the very young, the very old, and the vulnerable. So tour de force from all of you, thank you very much. I'm pleased to be in Ian Barr's section. We normally have him on first, and so I wanted to know, how was it for you, Ian? But before I ask you some serious questions, I want to know what Darwin is like as a new hotspot, and more seriously even than that, Ian, Yamagata, can we hope for actual eradication, or is it just a temporary elimination? I'll start with that question.
Yes, well, that is the $64 million question. I think, these viruses have been circulating in the Western countries since the early 2000s, so they've had a pretty good run. The B. Yamagata virus, in studies we've done, showed that the evolution of that virus was a little bit slower than the other B. Victoria virus, and in fact, slower than the A viruses. So if there was any sitting duck, it was the B. Yamagata to go if there was a bottleneck, which we have seen, a severe bottleneck for influenza viruses over the last couple of years. So we're hoping it's gone, but I wouldn't get ahead of ourselves. I think some countries have done continued good surveillance for influenza, others it has dropped off. So until things are back to normal in terms of surveillance, and that might be another year or two, I think we still have to be a little bit careful about eliminating that from our thoughts and eliminating that component from our vaccines.
Thanks, Ian. Another follow-up question. I think all of us are fascinated by the diminution in flu generally and in other respiratory viruses, but also that some have managed to creep back in 2021. Now, I'd like to ask you as a virologist to explain why those viruses might be more transmissible and might be explained by an epidemiological phenomenon called the effective reproductive number being higher for these viruses, or is there a better virological explanation?
I'm sure everybody on this call has their own opinion about what's different about influenza. Certainly from studies we've done, we've seen that influenza doesn't really persist too much over the summer break. So we do get occasionally, we get viruses which live through the summer season, but usually they're not fit enough, or there's not enough of them for them to persist into the next winter. There are a few exceptions to that, I should say. So I think that, what we've seen for influenza is clearly the majority of the epidemic is caused by reintroductions from either the equatorial regions or from the Northern Hemisphere each year. And they're the big drivers of the major epidemic outbreaks. And the other viruses, they seem to be able to hide away in the society, maybe in different age groups and maybe asymptomatically where we don't pick them up. And persist for longer periods of time than influenza seems to. But there's probably many factors going into this, not just the introductions.
The issue of co-administration you covered nicely, that is COVID and flu vaccine in separate arms at the same time. We had a very nice talk earlier today about that as well. And we also had something put in the Q&A with a recent reference, and I refer people to look at the Q&A for that. Did you want to comment any further?
No, look, I think it makes good sense. I'd just like to see ATAGI come out. They seem to get more press than anybody else these days, so I'd like to see them come out and make a clear recommendation that this is the go for 2022. I think there is, a lot of things going on at once, and some clear guidance from ATAGI, I think, would be useful in this instance.
Thanks, Ian. Peter, I'll turn to you next. Well, I think we can give you 3 stars, even though you didn't give too many stars out yourself. But you have my approval, Peter, even if you didn't show it to any other people, your talk. Thank you. I wanted to know about Pneumosmart. You gave us some nice information about that. And what do you think? I want to talk about impacts. I want to talk about change. I want to talk about how we can make things different. What do you think Pneumosmart has done? What could it do? What could other things do if it's not doing its job?
Well, it could do a lot more than what it's doing simply because of lack of awareness of its existence. I think it's highly developed to assist the busy provider in a time-pressured situation where they're wanting to give complex advice and to help make it simple and easy to understand for informed decision by the patient. And so it's already there to be used, but I don't think it's been promoted enough. I think if you ask most vaccine providers, they won't know of its existence. So promotion is the first thing.
So to follow up on that, you noted that 50% uptake for flu in children, less than 50% uptake for vulnerable people, and
for pneumococcal.
For pneumococcal. What key 1, 2 or more things do you think we should be doing right now to improve uptake?
So I think assisting to make the discussion simpler is the highest priority. Number one, that there's need for a discussion, and number two, to make it more fluent and understandable. What are the salient points for the person to make a decision, and cost, because there are significant cost issues involved, even to people who are recommended to have the vaccine. I think that needs to be upfront rather than obscured in the detail of the recommendations.
Michael Woodward made a couple of comments. I'll summarise by saying that he was concerned you were too generous in your evaluation, and that the change to using PCV13 for the elderly, he was essentially asking what disease could that vaccine prevent, and what would you like to say to that? Well,
I think the point is well taken, that it's contentious as to the technical impact on the strains, the clinical outcomes from the recommended changes, and I think there's a number of experts around the table here, much more qualified than I. I think the paper I referred to, Rob, you're an author of, discussed the how contentious that is, and the divergence of expert opinion as to whether those changes made for the existing guidelines are actually the best clinical decisions. But rather than me get into that technical discussion, I take Michael's point, and I think it's an evolving feast of information to digest, with the number of strains, their epidemiological changes, strain replacements, vaccine improvements, all feed into that quagmire of clinical decision. I think those are important for the experts to discuss. My contention is that all of that has value, but the greatest impact on reducing the effectiveness of the NIP is not the exact strain composition as it will evolve as information matures, but it's that providers can't implement it. If you can't deliver the program, I think is a greater impact than the actual strain discussion. That's for another talk.
Okay, so a question from John Lett. I'll leave you a moment to look at it and maybe to type an answer, and I may come back to you if we have time with that question from John Lett. I want to turn to Gemma. Gemma, you've done a great job in the RSV area, and I know that you're moving on to being a postdoctoral fellow at the Sydney Children's Hospital. Congratulations on that. I know that you presented very clearly the world and Australian evidence, but you didn't say how much of it you'd done yourself. So would you like to reflect on your own research and the fact that the 20-year review found, or 21-year review found 20 deaths, and how much disease was hidden, how many cases of RSV causing death you may not have been found? Would you just like to reflect a little bit on your own research?
Yeah, sure. Thank you, Robert. So that was a recently published study. We undertook a 21 retrospective review in a large urban Sydney hospital. So we took a really deep dive back and looked at any case where we found an RSV detection in a child who was hospitalised and then went on to die. And we looked at these cases in great detail with an expert panel to determine whether or not the panel believed that RSV contributed to the death of that child. So we really did a very detailed review of these cases. We knew we were looking at something that was probably quite infrequent, hence we looked over this long period of time. And positively, we did find a relatively few number of deaths. However, we did still find these deaths in these vulnerable children, these vulnerable populations. What sort of limitations, though, however, we were looking in this very well-resourced setting. We really need to do this type of research and this detailed review in less resource settings to understand what the frequency of RSV-associated death is like.
Am I correct in noticing that 100% of the cases had comorbidities?
They did. That is correct.
And
every case.
Yeah, and over 50% were required in hospital?
That's correct. So those were quite both quite striking findings. So every child had at least one significant comorbidity, which of course contributed in some way to their death as well. And over half actually acquired that infection, the RSV infection, in hospital. So quite a striking finding, and I think something that is probably under-recognised, this importance of nosocomial RSV in the hospital setting, and it's something we're beginning to hear a little bit more about now.
Great, thanks. Can I flick back to you, Peter? Jonathan Wong's asked a couple of questions about cost saving by vaccination, keeping people out of hospital. More recently, wouldn't the vaccines be more valuable if people took into account secondary issues like not just hospitalisation but other cost benefits as well? What do you think, Peter?
Well, I think the cost benefits applies at government level for decision of funding, and it exists with the individual. And it's an important message that individuals, I think, understand that cost is one part of the equation of value. That is, a lot of people will value a condition they've heard about or aware of, that they've got family members or other people they know, for example, shingles, who suffer severe disease, but not too many people, until prompted by their GP, will be aware of pneumococcal disease at all. So I think there's an added challenge there. I think so. Cost impact for the individual is an informed individual decision. Cost effectiveness for government is always, that's something I'd hope they'd be examining closely.
Thanks, Peter. And now you may not be aware, but you've all just been seconded onto ATAGI, and you need to show your benefits and your relevance. And so, Ian, you've already said you wanted to have clear guidance on co-administration. Is there anything else that you would like to see implemented in 2022 under the new Ian Barr administration?
Look, I think we've had enough changes to the influenza recommendations. I think from here we would go to an overall absolute recommendation for everybody and not pick and choose, but I think we're a ways off that yet. Thanks, Ian. Gemma.
Oh gosh, you put me on the spot, Robert. Look, I think it's a little bit hard to say for RSV because we don't yet have a candidate which is available yet. But certainly I think it's something that we should be looking at very closely. We've got quite a few really promising candidates coming down the line, and I know there is a lot of great work being done already in Australia. So I look forward to seeing that continue to unfold. Thanks, Gemma.
Peter, briefly, before we wrap up,
I'd simply say that ATAGI, I think, needs to prioritise greater. Certainly the focus is important on evidence basis for every recommendation, but a very important priority needs to be at implementation. How implementable are the recommendations? And we're seeing provider paralysis with COVID recommendations. Admittedly, it's so new and evolving, you can understand that that's complex, but for something like pneumococcal or other programs where there's a very big cost difference for recommendations versus funded, I think they have to consider better the implementability of the program.
Great. Well, look, thanks everybody. That's been a great session. I look forward to it being recorded well so we can go back and revisit, and perhaps people might email the speakers if they have further burning questions. Thanks everybody. Great.